So hello everybody, greetings from MedTalks. And we, in association with Simao and others, we are organizing the second virtual conference, and now we have the fourth lecture. All of you might be wondering that how will a cardiology practice post-lockdown would look like? We'll be able to consult a cardiologist with the patient together on a internet platform. Will the cardiologist will start examining the heart from the back? Will they limit their examination with the patient? Will they start doing echocardiography screening more than the detailed examination? That means once you have done a echocardiography, then you will start doing more of a limited echocardiography so that your patient contact time is lower. If you are wondering about that, let's listen to Dr. Wonder. Dr. Gurpreet S. Wonder, a professor of cardiology at Hero DMC Heart Institute, Ludhiana. Ladies and gentlemen, I present to you Dr. Wonder.
Thank you, Dr. K.K. Agarwal, and a very good afternoon to all who are participating in this mega symposium on how we are going to figure out in terms of how our practices are going to change post this lockdown, which is not going to be one event actually. The lockdown is going to be released in a staggered manner. So whatever we are going to discuss is actually, it's a very dynamic situation. And I was just noticing, although COVID-19 is a infectious disease, there are people from various specialties talking here because this particular infectious disease has impacted the lives of all of us, whatever field of medicine we are practicing. Actually, the story might be looking a little bit longer to a lot of us, but if we might reminisce, it was only on 31st of December that China from Wuhan reported first to WHO. Some people feel they reported a little late. The cases started occurring around, and by 30th of January, WHO's global health emergency declaration happened. And on 11th of March, global pandemic was declared. And this was a pandemic after the H1N1 pandemic. You might remember 2009, we had the earlier pandemic. And so this one came on 25th of March. Our Honorable Prime Minister actually declared the first lockdown, and the second lockdown we know started on 21st of April, and now we are going through the second lockdown, which is going to end by 4th of May. And some people feel there is going to be a third lockdown. Punjab has already declared actually that there will be a third lockdown where curfew is imposed. So we are all actually in different phases of this lockdown. And this adversity is actually posing a challenge to us in terms of how we look after our patients, how we run our systems, whether it is a single person clinic or whether it's a big hospital, how to make our hospitals deliver the same level of services that we have been delivering to our patients earlier. Actually, coronaviruses, most of us, you will recollect when we were doing our MD in medicine, we used to leave viruses and we used to focus on systems because we used to get cases from various systems in our examinations. But today, coronaviruses have made me study more about viruses than in the last 1.5 months than actually I would have studied cardiology. These viruses got studied in 1960s. They do cause a not so common, but a rather uncommon kind of a cold. And you will recollect the previous epidemics rather occurred in 2002 from China, again the SARS-CoV-1, and the MERS occurred from Saudi Arabia in 2012. But these were much smaller than this. They both originated from bats, but they had a much lesser impact on their lives. This, I just thought, is a familiar observation with all of you, that 81% of these individuals have a mild disease, 14% have severe disease, those who have hypoxemia, dyspnea, and they need to reach the hospitals. About 5% are critical, and 2.3% have fatalities. We know elderly, males, smokers, obese, and those with comorbidities like hypertension, diabetes, coronary artery disease, they have higher fatalities. The death rates, as have been shown on this slide, actually have been variable. India is lucky in the sense that the mortalities in our country are much less people are, I would say, the media has played a big role in this, and people are more scared than actually what is happening. As someone has said, खौफे मौत है किस तरह दुनिया में, खौफे रब होता तो क्या बात थी. We are actually more scared of this disease, which is causing actually reactions in terms of patients not coming to our hospitals. In fact, even in Japji Sahib, Guru Nanak Dev Ji says, ना ओ मरे ना ठागे जाए, ना ओ मरे ना ठागे जाए, जिनके राम वसे मन में. If we have faith in God, and we are actually a land of many gods, land of people who believe in God, and that is possibly one of, people have given various theories, BCG, malaria, other things, but possibly this is the reason. And of course, a bigger reason is that the lockdown in our country was imposed early. Lancet, a couple of days back, gave an editorial. Lancet is actually somehow negative to our endeavors and efforts. And they did discuss about this lockdown, and that's possibly also the reason Dr. Agarwal thought we should discuss this as to how we are going to start our practices in a staged manner so that we are able to deliver healthcare services to our patients. I would say, disclose here that this is an unprecedented situation, and situations are changing. You know as much as I know. I am going to just present some of my thoughts. Some of you might agree to them, but you might differ in certain issues. As our nature is, some people are more aggressive, some people are less aggressive, some people have got very scared, some people say it's nothing. Possibly a midline needs to be adopted, and we have to learn. We keep learning, unlearning, and relearn, because this disease has really made us fast track the way we are publishing our data. And I'm told there are 500 clinical trials which have been registered today in terms of how this disease is presenting and what are the best modalities. A lot of you would be knowing already that 2 days back we had remdesivir was showing a lot of promise, and Lancet and New England Journal of Medicine, they published 2 trials totally differing. And that's where we are. I would say we need to develop our own protocol in our own hospital, because our hospital systems are different. The number of infrastructure, number of people that are available is different. But I would emphasize here that we need to share responsibilities. We need to take everybody on track with us, not just the doctors, the nurses, the paramedics, the hospital administration, the class 3, and the cleaning staff, because it is a team effort which will make a difference in terms of how we are able to handle the situation. Of course, you are the most important ingredient. Look after yourself, have good diet, good food, take adequate rest. Good sleep is very important. Yoga, meditation, positive frame of mind. These are some of the things which will take you through this particular period. In terms of OPD in our hospital, we have actually developed a help desk for people who come with fever. And there is a triaging. We have a fever clinic where these people are referred. All patients are made to enter only with a face mask. And initially, we were insisting that a single attendant comes. But in Punjab, there is a tradition, the whole village would come with the patient, and they would want to share the difficulty and sorrows. But at present, some of these patients who are young, who can look after themselves, we only let just the patient in so that the social distancing is effective. Our endeavor is to only do the necessary investigations. And what we do actually in our institution is we have a look at these patients and we send them homes. Their reports are sent by mails and WhatsApp. And even a part of the discussion that they do with us, we take their phone numbers and then we talk to them later, so that whatever are their fears and worries can be addressed and their interaction with us is less. We do make an effort that these individuals do not come as attendants to our hospital: elderlies, males, those with comorbidities, obese, smokers, because we know this is the subset of patient individuals who are at a greater risk. So they certainly should not form attendants, and people should come with young individuals when they come to the hospitals. Every area will need to have their own states map displayed for the doctors, And I would say Ludhiana was a couple of days back in the orange zone, but now we are in the red zone because some people came, some migrants, and there were some students who came from other places. So today we are also in a red zone. The amount of PPEs which are required in the emergency area is obviously much more than the OPD. What we have developed in our hospital is we have developed these transparent kind of curtains, and we also have these screens in front of the doctor so that your patients are not coughing directly into you. I'm not saying this is the best method, but certainly we have indigenized for ourselves, and you people can all do according to your methods. I was just hearing Dr. Manoj was saying earlier, there is a consent form which we have developed. I just put our consent form. You need to put your own consent form so that people know what kind of risk they are having. And when they are entering a hospital, there are other patients, and healthcare delivery would obviously be of a different level. I know Dr. Agarwal is doing actually with the ISHRAE, the ISHRAE, the Indian Society of Heating, Refrigerating and Air Conditioning in the afternoon at 5 o'clock. We need to look at our hospitals' ventilation, our hospitals' protocols for air conditioning, because they are saying that we should have more air, windows should be open, and closed areas should be looked after. So there is an advisory from the ISHRAE which you can use. We all know this RNA virus actually is sensitive to heat, and there is a fomite theory, it can stay for a longer period of time on some surfaces, and thus there is a big importance of actually cleaning your hands with soap, shampoo, cleansing agents, alcohol. And it is actually this crown-like appearance, the halo-like appearance, which is due to the spike S protein, which is the culprit actually, which attaches to the ACE receptors. This is the culprit, and we are looking for a vaccine development on this particular culprit only, which lends the name and the appearance to this virus. Cleansing protocols in a hospital are very important. The All India Institute, the Ministry of Health has given protocols, and there is this 5-bucket, initially water and surf, then plain water, then phenyl, and then 0.5% sodium hypochlorite. So develop a protocol. It's not so difficult to develop a protocol, but your hospital staff, the cleaning staff, should all be aware of, and they should be well protected also. Your own attire would include, of course, head covers, shoe covers, masks. So the way you will be coming to the hospital will be very difficult, impermeable clothes. You will not bring a lot of your accessories. And of course, we've never learned donning and doffing, which is going to be learned for the first time. A friend of mine, Dr. Rajan Sharma, the IMA president, actually was telling me that studs have developed these face shields, and these are called as doctors' face shields. We also need to have head covers, and all these things will subsequently be required. The N95 masks are luckily available in our country. My daughter works in New York, and when this pandemic epicenter occurred in New York, they did not have N95 masks. So in that sense, I would say we are all very fortunate to have these. The All India Institute has given this protocol. How to use, each individual is to be given 5 masks, and these can last for 20 days once you keep them in this kind of a container, and you use every 5th day. I'm sure you are aware of these protocols. So you need to adopt these protocols actually. It's not just the awareness. And at the same time, keep a good attitude, keep your morale positive, because these are difficult times, and unless you are able to keep positive frame of mind, you will not be able to, and you will see, of course, a lot of these masks which are not effective coming up. Other people are indigenizing, and I know this is a rain poncho which they have developed for intubation. Now we all know during intubation, BiPAP, nebulization, cardiopulmonary resuscitation, these are actually events which cause a lot of aerosolization, and the viral load increases, and the doctors are at the highest risk. So anesthetists need to take a real care of themselves, and these kind of ponchos, the plexiglass box has been developed. People have really indigenized and the Indian Jugaad system, which is so very prevalent in the city of Ludhiana where I work. People are using, and we develop.
Welcome back, viewers, and joining us on this broadcast are Dr. Ashish Sahani, who's an assistant professor of Center for Biomedical Engineering, IIT Ropar, as well as Dr. Vivek Gupta, who's from the Hero DMC Heart Institute, and in fact, the specialty of these two gentlemen who have worked on a containment box to protect our healthcare workers. Thank you so much, gentlemen, for joining us here on Republic TV. We'll go across to Dr. Ashish Sahani first. This is a very unique kind of containment box that you have, in fact, come up with. If you can take our viewers through the details of the same, and how will this really protect or help our healthcare workers who are, in fact, fighting on the front line of this COVID pandemic?
So we have created this kind of a containment box, and which is very cheap and easy to make, and other people can actually make for themselves. Coming to the cardiovascular changes that occur in COVID-19, actually the troponin rise occurs in about 20% of these individuals. And this early study from Wuhan showed us that those individuals who have trop positive by HS trops or otherwise, in fact, there is a dose response curve. More the rise in troponins, worse is the prognosis. And in fact, people who have high troponins and baseline cardiac disease, they are worst. Those who have high troponins but no cardiac disease, they are at a second level. And of course, those who have neither this disease nor troponin rise, they are the best off. The spectrum of cardiac involvement is significant. There is myocardial injury. As cardiologists, we have all been learning about myocarditis that occurs with flu, with influenza, but this causes actually myocarditis to a larger extent, although this is primarily a respiratory disease and it causes ARDS. Now, a lot of people feel it's not the ARDS. Actually, it is a microangiopathy in which microthrombi are formed all across the heart. But we know influenza also increases the risk of acute coronary syndromes by 4 to 6 times. So you will see more coronary syndromes. Sudden deaths have been reported. People who have improved, even they go on to develop sudden death. And somehow the experience from China was, in terms of myocarditis incidence, was much higher. But the US reports show us that myocarditis incidence is somewhat lesser. But we have, some people feel there is an element of stress cardiomyopathy, the Takasubos, the inflammatory reaction that occurs, the cytokine storm that happens, that also causes immunological damage to the heart. And we know the right-sided heart failure that can occur in patients who have predominantly a lung compromise. So these are the various methods by which the heart get involved. And not the last, but one of the most important things which is getting significant attention these days is the occurrence of thromboembolic complications. And we today know that some of the investigations that we will be doing in our patients, a lot of people have concern, people come with doubtful disease, what to do. Actually, lymphopenia is seen in almost 80% of the patients. There is a decrease in T cells, especially the CD4 and the CD8. And so there is a domination of macrophages. So this can be a marker, actually, even if you are a cardiologist or some other specialty. TROPs, of course, are important. The natriuretic peptides are very useful since they are a part of the myocarditis process. And once you have D-dimers which are raised, so we will be giving value and importance to some of these investigations like CRP, ferritin levels, interleukin-6, some of these things which we thought are not so important, they are going to gain more value in our clinical practices. Of course, chest X-ray is to be done. And as Dr. Agarwal mentioned, echocardiography is an issue. The Cardiological Society of India is coming out with guidelines as to how best to do echo. And as he pointed out, there are issues because your time of interaction with the patient is longer. So echo should be done, depend more on BNP levels, clinical examination, as he said, safer from the back, from the front. So these are some of the things. One of the very important issues which has been gaining attention of various people is whether people who are on ACE inhibitors and ARBs, whether to withdraw these or not. The guidelines came early. The Indian guidelines also, the API also gave guidelines and said we should not withdraw. But this particular study, which came in circulation on April 17th, shows that if we do not withdraw ACE inhibitors, ARBs, the mortality is 3.7%. But if we do not, people are not on these, the mortality is. So certainly we should not withdraw. Actually, the concern is because the virus enters the body through the ACE receptors. Now, coming to what has been pointed out to you, actually, the OPD visits that we will be having will significantly be different, because in US itself, Harvard University and FRISA, a healthcare technology which looks at 5 million outpatient visits, has shown that there is a significant decrease in the number of visits that happen to a cardiologist, almost 60% more so for ophthalmologists, otolaryngologists, but some other specialties patients are coming. Area doesn't make a difference whether people are educated, less educated. There is a fear of patients to come to hospitals, and so the OPD visits have actually decreased. Of course, as I said, you need to have these thermometers, the non-touch thermometers, so that you let only look after your security staff, get them on the same stage as you are, make them learn what are the precautions they have to take. And actually, all adversities bring some innovations and positive things. And this is one actually very significant. Telemedicine has come in. In fact, even in US, actually, I was just reading in mid-February, only 0% of the consultations were virtual visits. And in April, middle 30% of the visits. In some hospitals, almost 80% of the visits are actually virtual. And so telemedicine has actually come, and it is here to stay. There are many telemedicine portals, and actually it is said that we should use the HIPAA, HIPAA, the Health Insurance Portability and Accountability Act compliant portals like UP Docs, VC, Zoom for Healthcare, Doxy.me, Google G Suite, the Skype for Business. These are some of the portals that you can use. The world is using all over. My personal take on this is actually a part physical, part video consult. The government of India has also given guidelines. Consenting issues are there, but if the patient is making a call, then consent is implied. But if you are making a call, then consent has to be known. The patient and the doctor both have to be identified in this. Looking at the hospital admitted patients, how we will be going through, actually we have to learn, as I said, you have to develop areas of donning before the patient care, and some hospitals are making donning and doffing areas very close to each other. Doffing areas, I think, are the areas of biggest infection, and we really need to actually look at how we sterilize the doffing areas so that they do not become portals of infection. This is another very important actually issue which people are actually, I was participating in one of the symposium with some physicians from Mount Sinai, and they also feel there is a report from Austria which shows that there is a 30% decrease in STEMI patients who are coming to the hospital. We ourselves have looked at our data, and patients of STEMI are coming less often. And it is actually felt that a lot of these people are reporting late, and some of these, in New York, there is data that mortality has increased 6 times as compared to the same month last year, because patients are not reporting. And so the American College of Cardiology actually has started this COVID hub, which educates the cardiologists, and a Cardio Smart for public education. The CSI is doing the same, the API is doing the same, and the IMA is also actually now looking at how we can educate the public so that this fear goes out of the minds of the people. And I'm sure Dr. Agarwal can do a great job in this with his access to multiple physicians across the country. We all fear actually that there is going to be a downstream effect, the collateral damage that is going to happen with these people coming late. There will be many more heart failure patients, and so there is going to be an overshoot phenomenon which you will see after the lockdowns open or are relaxed, because some of these patients who are holding on, they will be coming to you now. Develop protocols for inpatient, just as I said, for outpatients, share duties. Rounds do not need to be the same way as we used to have. And now actually we have to share responsibilities. Maybe a doctor who goes in, brings the diet for a patient. You don't need to have residents accompanying you for the round. So the number of people being exposed to the patient has to be actually worked out and implemented rather than just being discussed. We in our hospital actually have created, we are 4 senior consultant cardiologists and 4 junior consultant cardiologists, but we are now functioning as a single unit so as to share our, actually we need to pool in our resources, the manpower and the know-how, which we are trying to do now. So less number of people, patient counseling at times, even for admitted patients, can be done on phone, and we do not need to spend direct contact time with these people. I'm almost to the end of my presentation. Actually, I'll just share this little editorial. Bill Gates have given responding to COVID-19 a once in a century pandemic. That is how he has titled it. It's of interest because some general physicians must be actually listening to this discussion. He says, to quote, "It is essential to help low middle income countries to strengthen their primary healthcare system. When you build health clinic, you are also creating part of infrastructure for fighting epidemics." So the single person clinics, which is actually a hallmark of Indian medicine, need to be encouraged by the government, because they not only help in managing patients cost effectively, they also help in reporting of disease occurrence. So friends, I would end here by just repeating some of the things that are very well known to you. Be safe. You are very important. Keep a distance. Help others, your staff, your paramedics. Let them be safe, because if one person gets affected, so many get affected. Look after yourself. Anxiety, constant surprise, these are something which they are wearing and they are not good for you. And take a episodic century. It is a little bit of a longish issue that we are dealing with, but if we will be strong within, I'm sure this too will pass. Thank you, Dr. Agarwal, for making me a part of this mega symposium.
Thank you, Dr. Wonder. It was a beautiful presentation as far as what cardiology practice is now and would look like. Wake up, all the viewers. COVID is going to stay. Corona is going to stay. You need to start your practice with a change. Involve telemedicine, have multiple specialties, come on the Zoom or come on the electronic platform and discuss with each other. If you don't have to have, if a ICU is having 6 patients, 6 consultants, you may to share up what Dr. Wonder has said. Why do you need to have 1 patient per consultant and everybody walks in? Why don't you share your practice? The time here is to consolidate, and together we can fight. I have, because of the short of time, I have 1 question and 1 comment. And my 1 comment is that there will be no more time for people to ask for a CD after the angiography report. Now they will only start asking for a link. Give me a link. My other doctor will see the link and open it virtually. So handing over the files, handing over the CDs probably will go away. You can still charge 1,000 rupees, which you are charging for a CD, but you will start selling your links so that other persons now internationally, the international consultations will also open up now. The only question is, in heart failure, what about SGLT2 inhibitors, because they do cause ketosis?
The SGLT2 inhibitors are actually to be avoided in patients who are acutely sick. So they are primarily drugs which are useful in chronic heart failure and stable patients. So I would not recommend use of SGLT. This is a very dynamic actually process, the COVID-19. And there will be a lot of patients whom you're suspecting to have COVID-19, but there will be some who will prove to be COVID-19. And we all know there is a 67 to 69% positivity of the RT reverse transcriptase PCR test that we do. So there will be some patients whom you are having. That's why the concept, just like in HIV, we have universal precautions have to be adopted by all of us. So SGLT2 inhibitors, yes, patients who are in chronic heart failure, they are of great use. We have multiple trials. In acute situations, avoid these, especially in a very hyperdynamic situation like myocarditis in patients with acute COVID-19.
So like HIV, the test is not 100%. You know that in a window period, a person may be positive, but the test may be negative. Similarly, in COVID-19, a test may be negative and the person still may be having a COVID. So remember our old aged teaching and learning, treat the patient and not the investigation. See the patient as a whole. You may find evidence of lymphopenia instead of ESR should be normal in a viral fever. But if you say viral high ESR, high CRP, you know you're dealing with something different. Thank you, Dr. Gurpreet. Has wanted to be here with us. It was nice hearing you. And we will send you the link. Thousands of people are there who are watching this program, and we will collect all the questions and send you back all the answers. We will compile in the form of a book and send it to everybody. Thank you. Corona Namaste to everybody.